Atrial fibrillation is a purely electrical phenomena. Heart contracts, naturally heart contracts in very much of a concert. There's 4 cardiac chambers, 2 of which are the atrium and 2 ventricle. And they follow each other, contractions, and the heart does this, tuk tuk, tuk tuk, tuk tuk. When you have atrial fibrillation, the signals, instead of going from one point to the other, recirculates in the atria. And the atria, instead of contracting, kind of jiggles like a jelly. And the ventricle has irregular beats. So that's what the atrial fibrillation is. There's several factors that cause it. Sometimes it's congenital factors. People with high blood pressure, concomitant problems. Sometimes people with sleep apnea also can develop atrial fibrillation. But largely, this phenomenon is unknown. And there's several theories why it occurred, but we don't really know why atrial fibrillation starts. Well, incidentally, about 50% of people with atrial fibrillation don't have any symptoms. And people with no symptoms may actually have atrial fibrillation. But if symptoms occur, usually those symptoms are fatigue, shortness of breath. There's sometimes when the people doesn't know that they have atrial fibrillation, the first complication occurred is a stroke. And people all of a sudden become disabled without any suspicions that they may have atrial fibrillation. No, it doesn't go away on its own. Yes, atrial fibrillation is certainly a curable disease. It took us about 30 years to develop reliable methods of cure. It started in somewhere in 1989-90 when the big surgery was used for atrial fibrillation. When the patient was placed with the mid-incision in the chest, patient was placed in a cardiopulmonary bypass, and then so-called MACE procedure was done. The basis of that surgery is to create scars in the left atrium to prevent the rerun of electrical current. So in a certain way, we build this maze, and after that, the chances of cure are probably about 85 to 90%. Since then, the methods are more improved. We don't have to do midline sternotomy or a big incision in front of the chest. We can do with much small incision, percutaneous percutaneous intervention, and so on. There's a whole host of medication for atrial fibrillation. Unfortunately, they're not very effective. There's a two-part of that, two strategy. One is to control the heart rate, one is to control the heart rhythm. And there's several medications that use for that, and their effectiveness is very low. Therefore, people who at the risk of a stroke and people who would want to relieve that atrial fibrillation will need to have something different than just simply medication. They will have to have some intervention to be done. And again, it's determined by the treating physician. MACE procedure is the basis for all procedures that are done for atrial fibrillation. Well, if we're doing surgery for coronary bypass surgery, or for coronary bypass, or we're doing some valve surgery, sometimes we do concomitantly with that procedure. We also do a MACE procedure, which is again done through the mid-sternotomy. Patient placed on cardiopulmonary bypass, you're doing valve repair or replacement, and then in addition to that, you're doing series of lesion on the atrium to develop scarring. This could be achieved in several ways. It could be cut and sewn together, or you can deliver energy of radio frequency energy, electrical current, to heat the tissue, and then in that heating area, scar forms. Or you can do a cryo delivery, which is cooling the tissue to way below the freezing point where the cells are destroyed. However, the wall remained intact, and it also creates the scar. So in addition to that, there's other minimally invasive procedures that we are part of the development, and we're applying for the patients who are standalone atrial fibrillation. In other words, they don't have any other reason to have a surgery other than atrial fibrillation. Instead of being cut in the middle of the chest, you do a small incision on the side of the chest, and you can do the same procedure with the same lines through a smaller incision. That's called cryomaze procedure. In
Okay.
addition,
Oops, sorry.
in addition to that, there's the other procedures that's called mini-maze procedure. When you do a thoracoscopic or with the scope, you can go to the heart or to both sides or from one side, and you can do the same lines with radio frequency. Most recently, there's a developed procedure where even small incisions are done, not on the chest, but on the belly. And the surgeons go through the belly and the diaphragm around the heart and create about 90% of those lines. Then electrophysiologists go through the groin and do a touch-up in the left atrium. So that's called convergent procedure, that when the efforts of a surgeon and electrophysiology converge to complete the lines of maze procedure. Cryomaze, when done under general anesthesia, people come to the hospital, and when they go into the operating room, they will have to have anesthetized in the general anesthesia, and then the incision is made on the right side of the chest, and a little incision in the groin. Patient is through the groin placed on assistive circulation, and through the small incision on the right, we're able to visualize the heart and deliver a cryo lesion to the left atrium. This is one of the safest procedures that are done on the human heart with very little complication, and the effectiveness of that approach is 90%. In addition to that, we also can eliminate or put the clip on the left atrial appendage. The risk of atrial fibrillation is the risk of a stroke. A stroke forms because the left atrial does not contract, and an appendage, which is a natural appendage, like you have appendix, it doesn't have any particular role, but it's there. So when the left atrium does not contract, clot can form in that atrium, and then in that appendage, and they can travel then and cause the stroke. So if you put the clip and eliminate, physically eliminate, or anatomically eliminate the appendage, you eliminate the place where the clot can form, and therefore decrease the chance of a stroke. So we can do the same procedure with the cryomaze and the left atrial appendage. I've just done this procedure 2 days ago on somebody who is very happy now and get ready to be discharged home.